gentlemen, and welcome to Addressing Highest Individual Patient Demands from State-of-the-Art Standard Cataract Treatment to Full Spectacle Independence. My name is Florian Kretz, and I'm in the very happy position to have Andreas Borkenstein and Patrick Versace with me to talk to you a little bit about different optical designs, different fixation methods of lenses, and a large spectrum of different IOLs and different refractive optics to enhance independence for patients and get a better quality of life. We're going to start straight away with Andreas from Innsbruck, and he's going to talk to you about enhanced monofocal, latest technologies, and state-of-the-art cataract treatment.
So thank you very much. Good morning. I would like to start to show my experience and my results with the new Lentis Quantum and the Aconex Quantum. So let's start with the question, what is basic care in cataract surgery? So there is the MarketScope 2021 survey that more than 34 million cataract surgeries are performed worldwide, but in more than 90% of the cases, still monofocal IOLs are implanted. So we can say that monofocals are right now the standard lenses and the basic care. So let's talk about what are the requirements for a perfect IOL. Of course, the performance and the optical quality, the imaging quality in different lighting conditions. We all want a good handling, a good OR workflow, a stable positioning in the capsular bag, afterwards a low PCO rate, and of course a high patient satisfaction. The main focus to improve quality of life and achieve maximum patient satisfaction. Of course, you know, because of the increased life expectancy and the active lifestyle, the demands and the interest in spectacle independence is getting more and higher every year. And also the current presbyopia correcting IOLs were improved in the last years and are implanted successfully. There is still kind of side effect or possible undesirable effect like dysphotopsia, like halo and glare. And maybe this, next to financial aspects, is one of the reasons why only 10% of all IOLs are premium IOLs. So I guess the correct balance is the key and the main topic here. Of course, there was a change in activities, daily life activities in the last decades. So we as surgeons have to think about it when we do the pre-operative examination and talking with our patients. The distance ranges are the most important thing, in my opinion, for the right selection of the best option of the IOL in the individual case. So let's talk about EDOFs, enhanced depth of focus lenses. You all know a good visual acuity should be comparable to the monofocal IOL. We want to improve the intermediate visual acuity and the depth of field and achieve spectacle independence at working distances. And on the other side, we don't want to add additional risks like dysphotopsia and problems in mesopic conditions. There is one AAO consensus statement defining and talking about the criteria and the performance, but there are lots of different classifications and groups in different journals, and therefore it's sometimes not very clear to differentiate between EDOFs and enhanced monofocal IOLs. Here is just an overview, and we are now discussing Teleon's Lentis Quantum and Aconex Quantum through enhanced monofocal IOLs. So rotationally asymmetric refractive lens with two foci and two defined correction zones. And the good thing is this smooth transition between the zones, and therefore with this sector shaping, it is also suitable in larger pupils, and therefore no problems in mesopic conditions and if the lens gets decentered or tilted. When we talk about hydrophilic and hydrophobic material, you all know since decades there is discussion ongoing about refractive index, water content, content, OR workflow, financial aspects. Another survey showed that 65% of all lenses implanted are hydrophobic and only 27% are hydrophilic. But it is not only PCO prevention and the problem of calcification in the past. We all know several studies have shown that hydrophobic material can lead to good results with low PCO rates and lower YAG capsulotomy rates. But on the other side, hydrophilic acrylic with a higher water content and a lower refractive index can lead to a minimized glare effect and reduce reflection phenomena. On the other side, we have a very good biocompatibility. This is a good benefit in challenging cases like diabetes, uveitis, or other autoimmune diseases. And on the other side, like with the new hydrophilic material by Teleon, the problem of calcification is not there anymore. So we have a good material next to the hydrophobic. So here we want to differentiate. Teleon has a large portfolio. On the one hand side, the hydrophilic. We all know the MF plus family, the multifocal lenses. Then we have good experience with the true EDOF lenses, the Lentis Comfort, the MF15, with a target distance for intermediate of about 60 centimeter. Then we have the aspheric monofocal lens, and now the new enhanced monofocal Lentis Quantum, which has a target for about 80 centimeter. Here is some specifications. It is the same shape and design, blade haptic design, 6 millimeter optic and 11 millimeter overall diameter, and a refractive index of 1.46. And the brand new Aconex Quantum, the AN6Q, with the blue light filter and the hydrophobic material with 12.5 millimeter overall diameter and a refractive index of 1.54. In both, the Q-zone technology is the basic principle. It's creating a single extended focal point to create or increase the depth of field. And it is neutral to spherical aberration in the eye, and it has a smooth and stepless transition zone to prevent dysphotopsia. And therefore, it's kind of a bridge, or bridges the gap between a typical refractive IOL and the monofocal aspheric IOL. We wanted to evaluate if the advertisements by the company are true, so therefore we tried to do in a kind of cooperation project laboratory studies, optical bench studies, with the company TriOptics to have it objective. We used the OptiSpheric IOL Pro 2 and the WaveMaster. We did it with model cornea 2, different arrangements like centered lenses, decentered lenses, and tilted lenses. And as you all know, two very important things are MTF, the modulation transfer function, to describe contrast sensitivity, and on the other side, the Strehl ratio to measure the imaging quality of a lens. And we wanted to objectively verify the information that was provided by the company. So we did two studies, one comparing the Lentis Quantum, the hydrophilic lens, with the monofocal counterpart, and the other one, the hydrophobics. Here you can see, for example, centered lenses with aperture of 3 millimeter, in red the enhanced monofocal, and in black the monofocal counterpart. And a direct comparison to other spherical and aspheric lenses can show that there is no significant decrease. Even for when you have a large aperture of 4.5 millimeter, they are nearly similar. As you know, an aspheric lens has its benefits when it comes to large pupils and centered IOLs, but can be more sensitive when it comes to decentration. And you can see it here on the right side. An aspheric lens, when it is decentered, will have a decrease in the MTF. And the remarkable is that the enhanced monofocal IOL compared to a typical aspheric monofocal IOL has no decrease here. So we can say it is relatively insensitive. The same with tilted lenses here on the left side, the red one and the black one, again, a comparison, so no difference here. And when we compared the hydrophobic platform, the Quantum, to the counterpart, the monofocal AN6, again, with 2 aperture sizes, you can see, of course, there is a difference, but the difference is very slightly, and this could lead to very good results in real life. So here, a comparison of the through focus MTF curve. You can see the additional cusp in the Quantum lens, and the wavefront measurements showed that no relevant aberration showed up, except the one that was the peak to valley 0.53 and the root mean square 0.09. And the Aconex Quantum, the AN6Q, peak to valley 0.67 and the root to mean square 0.12. So to summarize this, we can say the improved depth of focus claimed by the manufacturer could be or was confirmed in this laboratory analysis, and there was some minor but neglectable decrease in contrast sensitivity compared to the monofocal lens, and therefore we can say both types, the hydrophilic and the hydrophobic, have its particular advantages in clinical settings. And the good thing is that you as a surgeon can decide for the individual case if you want a blade haptic design or a C-loop design, a hydrophilic or a hydrophobic, but you have the proven optic in both lenses. And the Quantum in both the hydrophilic and the hydrophobic are kind of insensitive to any kind of misalignment. These are just the results. And now some words to the clinical results of the first cases. Hydrophilic and hydrophobic here shown. We have by now no problems with the implantation process or unfolding, so there was no single case of handshake phenomena or sticking, no overriding. We are using the Medicel injectors. In more than 80%, the positioning can be done directly into the bag without the need of any additional instrument. And in less than 20%, I had to use a spatulum or the irrigation aspiration handpiece to center the lens or the trailing haptic in the bag. Even if you are doing the surgery in hyperopic eyes with shallow anterior chamber or use of Maleuin rings or iris hooks, the unfolding process is unproblematic. And it centers very well. So with our 2 sides, the laboratory studies and the clinical experience, we can say that we can prove and confirm the marketing advertisements. And in our facility, we are switching to enhanced monofocal lenses for a new standard care because we have advantages for the patients, improved quality of life, enhanced vision without additional risks, and on the other side, advantages for surgeons because it's a kind of easy selection. You can decide hydrophilic, hydrophobic, or blade haptic versus C-loop design, and on the other side, you can use it as a kind of standard basic care. And we believe that this new type and new class of lenses, enhanced monofocal IOLs, is or will be a kind of game changer in near future. So thank you very much.
Thank you, Andreas, for the great talk. Are there any questions from the audience? Well, then I have a question. We always talk about standard of care as monofocal, but actually monofocal has never been monofocal because we have spherical monofocals, we have apparating correcting monofocals, apparating neutral monofocals. Do you think that having a monofocal plus now as standard of care, what are the benefits behind increased depth of focus for basically every patient? The forgivingness or...
Yeah, right. I guess the forgivingness, and even if we are talking about elderly patients, for example, the first cases were average of 76 years mean age, profit in daily life. So it's not only about computer work and businessmen, but also about elderly people that come to me 2 months after surgery and say that the household activities are much easier. So I guess it's an additional aspect here. And on the other side, we had a talk yesterday, challenging cases like cases with gliosis, macular degeneration, a contraindication for multifocal lenses can be treated now with these lenses too, and you can reach some improvement there. So this is for me one of the best options now.
Yeah, are you able to say how much extra depth of focus the lens gives you? So if you look at a defocus curve, is it 1 diopter expansion or 0.75 diopters? Do you know the answer to this?
I guess it's 1 diopter, yeah.
Sorry, go ahead.
Yeah, I guess it gives 1 diopter of the...
One. Okay, yeah. Great.
Yeah, I have one more question before we continue. Do you think that the quantum optic really is like an entrance for younger surgeons that start with premium, or do you rather think it's a help for us as doctors because we can be off from target a little bit now because the effect goes in both directions?
I guess the most important is the pre-operative exam, not only with the devices, but talking with the patients for distance range. So I saw it when some refractive experts just using 2 or 3 lens types in their facility, they are sometimes not able to have the whole portfolio. So I guess for rookies and for beginners, it's not the implantation process or the surgery by itself, but the right choice and selection in the individual case. So yeah, it could be a benefit for both, for high volume surgeons, but also for rookies to start.
Thank you, Andreas. And just for you all to know, quantum is a symmetrical optic. And at the end, I know Patrick is going to talk about how you can center those types of lenses to really use the effect very well on the cornea with different haptic designs where we all hope that optic will on be too. So now I'm going to talk about addressing highest individual patient demands, custom fit with the rotational asymmetric IOLs. So here are my financial disclosures. I'm a consultant for Teleon. If we look at correction for presbyopia, we actually can learn a lot from the optical industry because they are working with different optical designs and individual approaches for a long time, and they found the right language to explain to patients which progressive glass is right for their individual care. And if we look at our patients, all our patients are individual, so you need individual treatments. You just heard from Andreas about the spherical aberration concept, which on one hand is forgiving, but also gives you depth of focus to help, but there's much more, and our patients need much more because they have different standards of life, and they need different sharp focal points or ranges of vision during their daily routine. So we often ask our patients just some simple questions regarding intermediate and near. One is it more a desktop person working on a computer, which on average is 70 to 80 centimeters, or is it more a person that is very mobile, that has like a tablet or a laptop, so they are closer? The other thing what is very important, has become even more important because our patients travel a lot, is are they accepting of dysphotopsia? If you look at dysphotopsia, actually many patients have it related to dry eye, related to the cataract already. But how accepting are they of the visual phenomena an optic can cause? And the other thing, which at least for me is very handy to always look into, is maybe did my patient have a micro monovision or a true monovision already beforehand, giving me a very easy option to treat them later on with combination of optics. But really what is like a very important thing, because it's not only related to the optic, it's also related to the dry eye of the patient, is how often or are they accepting of dysphotopsia? Because that is really something you have to take into account to have a happy patient. At least in my clinic, dry eye and dysphotopsia is the main complaint after cataract surgery. If you look at a varifocal optic, the rotational asymmetric design, you can see around 60% of the lens is designed for far vision, and the rest has an add power for the near. which makes it very handy because here we are not talking about a symmetrical optical design, so you can actually align those lenses better on the line of sight. If you look on optical bench analyzers here, some data from Gerd-Auffahrt from Heidelberg, you can see a diffractive optic splits light. And every time you split light, you have a loss of light. A refractive optic, which is just a combination of two optics, has far less loss of light, giving, or at least in theory and also in our practical cases, a higher contrast for the patient and a better use of the light. And especially in elderly patients, that can become very important when the macula is slowly changing. So you can see here the hydrophilic lentis line. It's an anterior sector-shaped segment with plus 1.5 at in the comfort, but you also have it available with plus 2 in the MF20 or the Visiotis, or as a plus 3 as the MF30 or as the MF30X. And you can actually combine those optics and look, does my patient rather need more intermediate or more near, and give an individual approach based on a lens with the same material and with the same design. So just here are some options that you can do. For example, with a comfort or an MF20, you can go for EDOF ametropic vision, giving your patient vision from distance to intermediate. They need spectacles for like small print, but many of them can read a newspaper already. What you can also do is you do a blended vision approach, which has become very popular also in laser refractive surgery, because you just give a little bit of a minus on one eye, and the binocular vision gives them a whole range of vision. And many patients are very accepting of it, or they had it previously anyways in their glasses. But you can also mix different optics. For example, an MF15 or MF20 with an MF30 or an M+X to binocularly give them good vision in both eyes for distance, and one eye covering the whole intermediate range while the other one giving them true near. Also, those types of optics can be combined, for example, with pinhole optics when you have irregular corneas that you couldn't really treat with another presbyopia correcting lens. And that still gives you a large range of vision and a good outcome for the patients, where otherwise it could be very difficult. We looked at the comfort line and compared it to monofocal lenses. And you can see here the outcome of our patients. It was an older group with over 80 in that comparison, and the visual acuity is pretty much the same for distance, but the EDOF lens with plus 1.5 has true intermediate vision in 90, 80, and 60 centimeters, and that's a range that our patients use or need in their daily activities. If we look at the optical quality using the HD analyzer, you can also see there's no real difference. So the optical quality of those patients is pretty much the same if they have an aberration neutral IOL or a lentis comfort. And then comes the interesting part, halo and glare. So those patients are old. And if you look at how many patients say that they have halo and glare, actually our comfort lens had a slightly better performance, but it wasn't significant at the end because of the number of patients. So there's no real difference in light phenomena with this type of optic for those patients. And that is really, I think, the true benefit if the patients are sensitive to their dysphotopsia levels, to give them an option for presbyopia correction. And if you compare the outcome of those patients to what type of dysphotopsia level did they have before the surgery in the cataract group, you can actually see that you decrease their glare and their dysphotopsia with giving them a rotational asymmetric optic with a low add power. So if patients have no acceptance for dysphotopsia, probably a diffractive lens will not be a good choice. Monofocal monovision is a good choice if they can accept it. The lentis MF15 is really like an option that you can consider in those patients, or to even mix and match the optic to reduce the dysphotopsia. And if you look at the simulator after the surgery and you compare those groups, you can see it's pretty much equal. The level of dysphotopsia is in the absolute normal range with a monofocal aberration neutral lens. But we do have some more data for those patients, and you can, for example, see here the defocus curves of the MF20 in one eye, the IC8 in the other, and the binocular function with the increase. And also here, they do have functional near vision with 0.4 logma in around 40 centimeters, which still offers them to read normal print size, not small print in that area. And if you compare it to the comfort results, you can see distance is very good, and the intermediate is good. It's just for the near, they do need spectacles, but without all those side phenomena as possible. So I think in conclusion, the comfort model is a really good lens that offers you all the benefits any monofocal has at the moment, especially compared to aberration neutral optics. And the lenses MF20 really can enhance intermediate a little bit more. But one hint about an asymmetric model is it's the only way that you can actually align the lens towards the line of sight of the patient, because you can look at your Purkinje images and you can basically place the segment in a way that you will always have the line of sight going through the distance focus, and not like in a symmetrical model where you can be off and it goes through the diffractive rings or beside the actual optical design. So there's a wide range of optics available that you can combine for your patients, and you can do a really individual approach. I think the quantum is a really great way to like start it, especially for your standard cases. And when you go in the premium sector, the individual placement of the lens and the different optics really give you a true benefit. So thank you very much for your kind attention.
So Florian, when you mix and match the IC8, the reduced aperture lens, with the MF20, you said, do the patients notice a difference in terms of light between the eyes?
Yes, the patients do notice the difference, but I only used it in those patients that have an irregular cornea or slight corneal scarring in one eye, and then we used the IC8, so they already had distorted vision and dysphotopsia beforehand. And I think there is just a better option, because to be honest, would you put a trifocal in both eyes if one eye is irregular? I wouldn't.
This mix and match approach, so I like it very much. So do you recommend to start with the far dominant eye and then do it the second eye in an interval, maybe 4 weeks later, to get the discussion with the patient again? Or do you recommend to do it right some days after the first surgery?
So the German system is quite complicated. Where I practice in the Northwest, I have to leave 21 days between the surgeries, otherwise we don't get reimbursement for the second eye. In Bavaria, we can leave 24 hours in between it. To be honest, I don't think that the timing plays any role. It's the counseling of the patient. If you do with the mix and match, it's actually not a problem, because they always have good distance vision with a rotational asymmetric design. If you do a blended vision approach, then you need to really explain to the patient, okay, we do your distance dominant eye now, so you will see distance and intermediate, and the near comes with the second eye, or the other way around. But it's just something that you have to explain to them additionally, depending on how long they have in between. If it would be my choice, I would much prefer to do it simultaneously on the same day, because then they walk out, they have straight away the effect, they can get used to it. I think that's a much better approach in the future, especially in premium surgery. Can we go? Yeah. So now Patrick is going to tell you a little bit how you can also work with these optics and how you can optimize it by placement.
Florian, thank you. Good morning, buongiorno. And my talk is less scientific, a bit more rambling. So here we go. You know, we've got a lot of lenses available to us, and you've got to wonder why we're even talking about new lenses. Now, the fact is the first multifocal lens was used almost 40 years ago with this Pierce zonal refractive lens, and it worked. Patients got good vision, but quality was not so good. It was sensitive to decentration, so of course that was not a successful design. And you've seen a slide like this already to say, well, for all the lenses we have, they all work. Why aren't all lenses some kind of presbyopia correcting lens? Rather than the small number, which is around 10 or 12%, the rest are not presbyopia correcting. There's got to be some reason for that. My disclosures. Let me start by talking about the problem as I see it, and there are two of them. And one of the first problems is exemplified by this young nurse who wanted really good close vision with surgery, wanted to be able to read the ampules, so I chose to use a Synergy, which gives great close vision. We did the first eye, and her vision was terrible. She's unhappy, bad for far, bad for near. She gets halos. Well, we knew she would, but the halos aren't even round. They're distorted. Everything's bad. So what's wrong with the eye? We go through all the normal things. Refraction's good. Cornea's good. There's no macular edema. And we start to think about centration of the lens. And looking at the eye trace, well, angle alpha, 400 micrometers, not too bad. When we look at her lens after the first eye is operated, it's decentered by almost 700 micrometers. The synergy is very sensitive to misalignment with the visual axis. So this was probably why her vision was poor. So we went back to surgery, we fiddled with the lens, and we were able to reposition it a little bit to get much better alignment with the visual axis, and she had complete resolution of her poor quality vision. Another case with the first problem is this time with a Vivity lens. This patient is sent to me after surgery. Bad vision. I'll do a YAG laser capsulotomy, which was done. So their capsule is now open. And again, it turns out that this lens is quite decentered from the visual axis. It's misaligned by 750 micrometers. And the Vivity is quite sensitive to decentration from the visual axis. Now, in this case, the posterior capsule had been opened, so we ended up explanting the lens at the patient's request and putting a lens in the sulcus with complete resolution of the symptoms. So my first suggestion is that if we can somehow better align our lenses with the visual axis, we will get rid of a lot of the problems that we experience, a lot of the outliers in the cases that we do. And the only way we can really align a lens with the visual axis is to somehow attach it to the capsular rhexis that we align with the visual axis. So that's one idea. The other problem, which we've heard already from both speakers, is this one of unwanted visual phenomena. It's halos and glare. And the fact is that the incidence of halos is basically related to lens design. This is the most important determinant for halos that patients will experience. And the fact is also that with diffractive multifocal lenses, every single patient, 100%, sees halos. They may not be bothered by it, they may not tell you, but they all see halos. It's intrinsic in the optical design of a diffractive multifocality. So my second suggestion is that if we avoid diffractive optical designs and use designs like the Teleon lenses, of course, the pure refractive asymmetric segmental lens, we can pretty much get rid of the problem of halos, the unwanted visual phenomena. So let's go. Let's talk about centration, alignment of a lens with the visual axis. What are we talking about? Well, the pupil's important, visual axis is the most important thing. Capsular rhexis, if you're putting a lens in the bag, it's pretty much irrelevant to lens alignment. And then we think about tilt. Angle kappa is something that's been spoken about for a long time, particularly in the context of refractive surgery. It's not so relevant to lens surgery, but let's talk about it because some of the literature still refers to angle kappa. Now, angle kappa describes the displacement of the visual axis from the center of the pupil. Angle alpha, which is the one we should be talking about for lens implant surgery, describes displacement of the visual axis from the center of the limbus. Simple. And the center of the limbus is probably a reasonable landmark for the capsular bag. So that's where a lens will sit, pretty much. And here's an example of a segmental refractive lens looking at the patient after surgery with the eye trace. And you can see the visual axis there going through the distance vision segment of the lens where it should be. Let's dismiss pupil alignment first. Pupil position with a lens does matter, dependent upon the optical design of the lens. There are case reports of the Alcon Restore and apodized diffractive optical design where you have correctopia, so the pupil is not aligned with the lens. The patients report visual phenomena. The surgeon does an argon laser pupilloplasty to drag that pupil back and make it better aligned with the lens, and there's resolution of the visual phenomena. Patient sees better. So pupil position does matter. Certainly with a segmental refractive lens like we're talking about today, or part of the things we're talking about, pupil position can matter. You can see what happens as the pupil gets smaller. If for some reason that pupil is not aligned with the center of the lens, it will have an impact. But let's concentrate more on the alignment of a lens with the visual axis. And some of the literature, to begin with, that looks at angle kappa, it's pretty clear in describing the fact that when a lens, or when a patient has a large angle kappa, a diffractive multifocal is likely to have more unwanted visual phenomena. there's a significant association between the size of angle kappa and the incidence of photic phenomena. Now, it's not a straightforward relationship. It's not a direct relationship. And you've got to wonder why not. Well, I'd say the answer is first that angle kappa is a bad parameter to use. It's variable and it's loosely correlated with angle alpha, but not directly. The second issue is that it's a bit dependent upon the depth of the anterior chamber, so the effective lens position. That will give variation in the impact for a given value of angle kappa. So there are reasons why it's not a direct relationship between angle kappa and the incidence of unwanted visual phenomena. There's this concept of a critical value for angle kappa, and the idea is that if a diffractive multifocal is put into an eye, and if the visual axis, instead of going through the middle of the lens, strikes the first ridge, you'll get poor quality of vision. Yeah, it's an idea, and there are values put out for what is the critical angle of angle kappa, and maybe it's about 10 degrees, which represents a physical offset of almost 1 millimeter. Now, you rarely get that in practice. But let's start to move towards looking at angle alpha, which is more important. Back to angle kappa, to finish off with that. This paper is very useful because it shows a clear relationship between the size of angle kappa and the severity of unwanted visual phenomena. They categorized angle kappa into 3 categories, and you can see a statistically significant increase in the unwanted visual phenomena as angle kappa gets bigger and bigger. But also importantly is visual acuity and spectacle independence was unrelated to the size of angle kappa. So we're really talking about quality of vision here, not quantity of vision. Now, angle kappa and angle alpha are loosely related, but it's very loose. An important takeaway message today, perhaps, is to tell you that angle alpha is a fixed value. It's almost always a displacement on the horizontal, and it's pretty much always around about 0.4 millimeters on average. But here's a slide in yellow, because this is a message to take away, is that angle kappa changes after surgery. So angle kappa is not a fixed value. It will change after lens implant surgery. Perhaps it's because of the lens somehow changing the pupil position or surgery affecting the pupil position, but it changes. Whereas angle alpha is a fixed value. It can't change. It's a relationship to the limbus, which is a fixed anatomical landmark. What's the tolerance? Okay, so for a monofocal lens, we have plenty of wriggle room. You can probably tolerate 1 millimeter of decentration before you see any problem. But for diffractive multifocals, I come away from reviewing literature thinking around about 0.5 millimeters is your cutoff. So if you have a displacement of the visual axis from the center of the limbus of more than 0.5 millimeters, that's angle alpha, you should not use a diffractive multifocal lens because you have a higher risk of getting unwanted visual phenomena. You'll hear often people talk about this idea of at the time of surgery, make sure you put that lens where you want it to sit. Align it with the Purkinje image. Okay, nudge the lens a bit nasal, so you better align it with the visual axis. Well, I'm going to suggest that's perhaps a waste of time. This paper from 2020 shows that pretty clearly. What they did was they categorized patients into one group, where they just put the lens in the eye and let it sit where it wants to sit. In the other group, they put the lens in and they deliberately tried to align it with visual axis. They found there was no difference between the 2 groups after surgery. It made no difference if you tried to put it somewhere. It was a waste of time. Okay. So how can we align a lens with the visual axis? The only way really is, one, to use a segmental asymmetric lens like this, where you can selectively place the near segment where you want it to be. That's one way. And here's an example of how that can work. If the visual axis is not in the middle, you can place the lens selectively because it's asymmetric to be sure the visual axis is going through the optic where you want it to be. Or we can use one of these lenses, the femtus lens, that attaches to the capsular rhexis, because then you have the option to have a lens that you put into the eye, you attach it to the capsular rhexis, and you've created your capsular rhexis using a femtosecond laser that's aligned with the visual axis. So now you have extremely predictable alignment of your lens, always with the visual axis. And this is probably the most effective technique we have right now to ensure perfect alignment every time of the lens with the visual axis. Easy to do, Surgery takes about 45 seconds longer than standard implant surgery. It is not a complex thing to do. You need a femtosecond laser, of course. You've got to be able to make a perfect capsular rhexis, and you have to be able to align that with the visual axis. You can't just randomly make your capsular rhexis. Now, there are many ways to make a capsular rhexis. There are femtosecond lasers. We have Catalyst, we have LensX, and we have the Ali Lens R, which is on show here now, which is one of the more advanced combination lasers. Zepto and capture laser, of course. This is an example of a femtos lens, and I've shown the near segment of the lens there down below. And we can very predictably align this lens with the visual axis because it's no longer sitting in a random position within the capsular bag. And there are two features of this sort of lens design to sort of understand. One is the physical design, and what are the potential benefits and impact of putting it attached to the capsular rhexis. And the second is the EDOF properties and how it performs optically with this segmental refractive design. So we did a study, it was published a few years ago now, and refractive predictability is excellent. But importantly, a lot of patients are able to achieve, we'll go back here, are able to achieve very good vision for both near and far without requiring spectacles. This lens is performing as an EDOF lens. When we look at the clinical defocus curve, it's very much like a lens like Symphony, but with a bit of extra extension of the defocus curve. So in practice, it's performing like an EDOF lens. So it sits over here in this kind of chart that you'll see as you go around, which thinks about minimizing unwanted visual phenomena balanced against the range of vision you can give a patient. And this is the refractive asymmetric design lens that we're talking about. And in this study we did, we had 60% of patients never wore glasses. The rest wore them sometimes for reading. That's a great outcome for an EDOF lens that has no unwanted visual phenomena. This is a clinical defocus curve that we're talking about. And when you look at the lens, you start to think, well, it's a bifocal design. There's a near segment and a distant segment. How can it be an EDOF lens? And it gets complex to think about the optics. We've already heard mentioned today about the use of modulation transfer function as a way to assess the visual quality of lenses. It can also be used to generate defocus curves. And often when you look at literature for defocus curves, they're generated by MTF in one plane only. But if you look at the MTF in two planes, so both vertical, horizontal, or tangential and sagittal, you get a different appearance. Let me show you. So if you take this asymmetric design and you look at the modulation transfer function in different planes, you'll get a different result. Because as you come across the lens, you have a different balance between near and far vision in different planes. Whereas if you do the same thing for a rotationally symmetric lens, so any other EDOF lens, any other diffractive multifocal, it doesn't matter what plane you look at the lens in with your MTF, you're always going to get the same curve. You have to, because the lens is symmetric. This has been studied now on the optical bench and both mathematically. At the top here, I'm showing you a rotationally symmetric lens, a diffractive multifocal. And if you do the MTF vertical and horizontal, you get the same curve. You have to, it's symmetric. If you add them together mathematically, you get the same curve. It's a bifocal defocus curve. Down below is the segmental asymmetric lens. And you can see that the MTF, taken in two different planes, looks quite different. And when you add them mathematically, you get the defocus curve of an EDOF lens. This has now been published, and this group did it both mathematically and also on an optical bench, and they found the same thing. So at the top, your right, is the final defocus curve that you can generate for a 3mm pupil. When you add the different MTF curves, summate them, and you get a defocus curve of a EDOF lens. For a bigger pupil, it looks a bit different. So that's how we get these clinical defocus curves that makes this lens behave very much like an EDOF lens. And one way to express how much vision patients get is to look at the area under the curve of a defocus curve. And the comfort, or the MF15, whether it's a Femtus or a Lentis or an Acunex lens, they all give greater volume of vision to a patient than the alternative EDOF lenses. And equally importantly is this lens over on the far right, the Femtus, the MF15, the comfort design, basically gave no unwanted visual phenomena. There's something about attaching this lens to the capsular rexus and having it right up behind the iris that helps to further reduce the incidence of unwanted visual phenomena. So it's a lens that can give us good alignment with visual axis, that can give stability of position and absence of unwanted visual phenomena. Now you need a laser to do this, of course, and there's a cost factor in that. Here's the Ali Lensar laser up on the stand. You can do a manual capsular rexus, but I would not recommend this. It's very difficult to give a predictable, consistent capsular rexus manually of the right size that is aligned perfectly with the visual axis. So yes, you can get away with it. I got away with it here because the laser went down. I'd promised the patient a Femtis lens. So we do a manual capsular rexus, which in this case is perfect, which is why I'm showing it. You can use Zepto. Now, Zepto was popular for a while. I think it's fallen a little because it's a bit cumbersome to use and there are potential problems with the use of this device. But it's one way to create a less expensive capsular rexus of a known size. Capsule laser is very promising. This is a beautiful, inexpensive technology that allows us to create a strong capsular rexus of a known size. But, you know, it's still fairly new in its technology and the delivery is still a little bit crude, so we'll see where this goes, but it's certainly a good option that may allow us to use more Femtis lenses in a more cost-effective way. Capsular rexus strength, well, you know, yes, it's stronger for a manual. It's stronger with capsule laser. The weakest capsular rexus that we create is the one we create with a femtosecond laser. But in practice, you know, we attach this Femtis lens, I can move it around and reposition it. The rexus is very much strong enough to support the lens. So in conclusion, I'm going to say that to me, the idea of capsule rexus fixation of a lens can eliminate negative dysphotopsia. We can achieve perfect alignment with visual axis every time. We can eliminate phimosis. We may get better refractive predictability once we get bigger numbers because we have a more consistent effective lens position. Eliminate tilt, and importantly with this optical design, being a segmental refractive lens, we pretty much eliminate unwanted visual phenomena. We give a good range of vision and high quality distance vision. And my final slide to conclude with is to say, if you take away one thing from my long talk, is to say that consider angle alpha, not angle kappa. Have some way of measuring that, whether it's on the Pentacam or the IOL Master. They all give you values for angle alpha indirectly, and you can work that out. And if you have an angle alpha displacement, so visual axis displacement from the limbus of more than 500 micrometers, I would say do not use a diffractive multifocal lens because you have an increased risk of unwanted visual phenomena. And if you're using a segmental asymmetric lens, like we're talking about here today, the segmental lenses, and you don't really want to worry too much about it, just put the near segment infratemporal every time. That optimizes your chance of having the visual axis go through the distance element of the lens. I thank you very much for your kind attention.